So the first goal really is to try to define traumatic brain injury and go through some of the statistics. First and foremost, I think it's important to remember that this is an acquired event, meaning this is not something that they're born with, or it's an anatomical or a metabolic issue. This is due to an external force that is affected to the brain, and it results in either temporary or permanent neurologic and or endocrine dysfunctions. Those injuries are often classified as a primary, which is the initial injury. Can vary from a shearing, a blunt, penetrating, or a hemorrhagic injury. And the secondary injury is the subsequent reactions to that primary injury. We'll go into detail about the difference between the primary and secondary and how both play a significant role. The injuries themselves are often categorized using the Glasgow Coma scale, which is based on eye movement, verbal commands, and motor skills that are applied once the individual typically gets to some type of medical facility. The biggest take home, however, really is recognizing that traumatic brain injury is a process. It's not simply an event. And that's one of the take home messages I'm really hoping to drive home. Likewise, just simply the awareness of endocrinopathies following traumatic injuries. Some of the statistics. This is an article or report from the CDC that was given in 2018, although it's referencing the previous decade. Essentially, between 2.5 and 3 million individuals, both adult and pediatric, have presented to the ER for some type of trauma, whether mild concussion all the way up to a severe injury. Approximately a quarter of those individuals wind up in the hospital, and about 20% of those individuals, unfortunately, suffer ultimate demise. The numbers on the slide in parentheses are highlighting the adolescent or child statistics and numbers. The interesting numbers that they've appreciated in the last decade is that the incidence of these injuries has actually doubled, about 53 to 57% increase in the last decade compared to the previous decade. The good news, however, is the mortality following these injuries seems to have decreased slightly, and that might be due to technology, specifically as it pertains to vehicles, which we'll talk about. The types of injuries is really dependent on the individual and the age of the individual. As we highlight in this slide here, the gray slide, or the gray line represents falls. The black line represents motor vehicle accidents, and the red line is unfortunately assaults. And what you want to highlight here is both at the beginning of life and at the end of life, the most common injury is, of course, falls. With that being said, as we all are aware, distracted teenagers and young 20-year-olds are often subsequent or suffer from motor vehicle accidents. Probably has something to do with technology, and it probably explains why our car insurances on our kids go up so high at that time. But they estimate 1 in 500 teenagers and young 20-year-olds will be in some form of motor vehicle accident that could result in either a mild concussion all the way to a severe injury. The next objective really is to kind of dive into the anatomy and the histology surrounding traumatic brain injuries. Really, the goal here is to highlight awareness as to how and why an individual who suffered traumatic brain injury could develop long-term sequelae, whether it's neurological and or endocrine. So I really hope that this is successful and helpful. I've had the fortune to work with Medivision. They created an absolutely excellent video that illustrates exactly what happens during a motor vehicle accident. So I'd like to take a few minutes looking at this slide, and then we'll kind of dive into deeper details.
During a sudden deceleration, as shown in the beginning of the animation sequences, the brain violently impacts against the inner surface of the skull at 2 times. First, when the head impacts with the airbag or otherwise stops its forward motion and begins its immediate, rapid, violent reversal of motion. And second, when the head impacts against the headrest and repeats the immediate, rapid, violent reversal of motion. By observing the collision from a view that follows the motion of the head, one can appreciate the deformation of the brain as it violently impacts against the front and back of the skull. Close inspection of an area of the outer surface of the brain and inner surface of the skull during the initial impact shows the soft, fragile brain scraping against the hard, jagged inner surfaces of the skull to create shearing forces. As the gray matter, comprised of cell bodies, and the white matter, comprised of axons, are of two different densities, the shearing forces create a plane of cleavage where many axonal injuries occur. The axons may be completely torn, partially torn, or separated from their connections with other cells. Thousands or even millions of scattered axons may be torn, but unless some of the larger and more resilient arteries are also torn, no bleeding occurs. Traditional imaging studies such as CT or MRI are not nearly sensitive enough to detect individual axonal injuries or even relatively large groups of axonal injuries. CT and MRI are designed to detect areas of bleeding. Unless a blood vessel or multiple vessels are torn, creating a relatively large bleed, these studies fail to demonstrate any findings that would indicate the presence of multiple, widespread, and microscopic axonal injuries that can result in devastating neuropsychological deficits. In situations when the forces involved are severe enough to result in injury to the blood vessels, the injuries to the axons are even more severe. An injury to one or more blood vessels results in the release of red blood cells into the surrounding brain tissue. CT and MRI are designed to detect blood, or after a period of time, the remnants of blood called hemosiderin. Large quantities of red blood cells must hemorrhage from a blood vessel or blood vessels to be detectable on CT or MRI. If even one small hemorrhage occurs that is detectable, it is an indicator that there are likely vast numbers of associated axonal injuries that are not depicted in the scans.
So I hope that you were able to appreciate that excellent illustration. Although there's one mechanism I'd like to highlight, this same phenomena is also happening to the pituitary because it also sits in its own technical skull or bony surrounding. So that same contusional mechanism is also at play with the pituitary as well. The different types of injuries are often categorized from primary and secondary. The primary injury, again, as we had mentioned earlier, is really the initial trauma, whether it's a blunt trauma, hemorrhage, or stabbing mechanism that results in immediate contusion, cellular destruction, often vascular compromise. The secondary injury is what follows. The secondary injury can be it occurs relatively immediately, and it can last for hours to days depending on the degree of injury. The secondary injury includes swelling, ongoing vascular compromise, and the inflammatory reaction to this injury that often can have both positive and negative consequences to the neuronal tissue. And this degree can help to understand and explain why individuals maybe at the very beginning have endocrine issues and or down the road eventually develop endocrinopathies. This slide really highlights another mechanism. As I had mentioned, there's the hypothalamus and the cerebral tissue, which is connected to the pituitary through this pituitary stalk or infundibulum. That communication highway is what allows neuronal communication from the hypothalamus to the pituitary. It further is encompassed by vascular supply. In the mechanism which the head is bounced back and forth, what winds up happening, because the cerebral tissue in the hypothalamus weighs more than the pituitary, there's actually an extension or a shearing, a mass effect that further pulls on the infundibulum, causing some additional tearing of not only the neuronal cells in this region right here, but also the vascular supply that comes down and provides critical fuel and blood to the anterior pituitary. So as you can imagine, with the separation of those two tissues, that this could lead to compromise. The other mechanism that's often not discussed is during the second injury, a part of that reaction is swelling. That swelling can also lead to almost like a compartment-like syndrome effect in this area. As you can imagine, because this is a confined area, that if I induce swelling in this tissue, it's essentially going to butt up against the surrounding bony structure and impede swelling. This is most commonly thought of phenomenal-wise when somebody puts in an ICP drain to alleviate pressure. Unfortunately, in this scenario, we don't have the ability to alleviate pressure. And so that swelling not only causes tissue damage, but it can further compromise that blood supply or the highway communication between the hypothalamus and the critical pituitary tissue. And I think this is why often there's a much significant delay. And again, this can be months and years after an injury when somebody ultimately manifests endocrinopathies. From a cellular perspective, again, this is a histological slide of the anterior pituitary. And here on the middle of your slide, this is the lateral aspect of the pituitary. And just as you saw excellently depicted in the video, if this is thrown up against the bony structure on the side, you in essence can create a contusion or a bone or a tissue bruise in that area, which will lead to cellular destruction along here, while also preserving the middle structures. Which interestingly noted from a histological perspective, your growth hormone secreting tissues or cells happen to be on the lateral aspect of the pituitary, which is almost assuredly why that's one of the most common consequences of traumatic brain injuries from an endocrine perspective. Fortunately, however you take this, that the critical endocrine axis, i.e. the adrenal corticosteroid production axis, is most preserved because it's centrally located. So from a mechanism perspective, it is preserved, which is obviously the most critical. And then your TSH secreting cells, as well as your gonadotropes, tend to be dispersed throughout the anterior pituitary. But that histologic slide helps to further understand why growth hormone deficiency is one of the most common consequences of traumatic brain injury, whether it's a child or an adult. Complications, clearly it can be a mixture of neurocognitive, movement, sensation, and even some type of disruption in a child, pubertal disruption, or hypogonadism, or low T syndrome, as is noted in the adults following traumatic brain injuries. This is why when I see an individual for poor growth or pubertal alterations, one of the questions I ask is, have you ever suffered a significant traumatic brain injury? Because what they often don't know is that injury years ago have any relevance to why they're here today. As you can see, some of the statistics I mentioned are pretty profound, that there's a large body of individuals out there who suffer injuries annually and subsequently long-term consequences. And it's really our job as providers to try to help bring awareness between the association of traumatic brain injuries and endocrine and neuroendocrine disorders, which is what I'm so blessed and pleased that the Human Growth Foundation is offering this webinar. Likewise, this tends to be a very non-specific complaints, so it's often hard to organically or confirm. The signs and symptoms of hypopituitarism, for those of you who work in this world, we all know it's very vague and nonspecific. It can be a difficult diagnosis to make, not only with the tools that we have, but also, especially in the adult world, there's also typically confounding factors, i.e. life, stress, comorbid conditions, medications that often can mimic these signs and symptoms and complaints. So it's left up to us to try to discern whether this is truly a consequence of that injury that happened long ago, which is a nice segue into my next goal or objective, albeit this is almost a virtually impossible objective to achieve, especially with the time limitations. But really what I want to highlight is just that, how difficult it is to try to review the literature and focus on why it's so difficult to review the literature and how hard it is to come up with a consensus statement. Despite those limitations, at the end of the day, we still have to take care of the patient that's in front of us who's complaining of some type of concern that may potentially be an endocrine organic disorder that needs attention. This is a great review article that was published in 2015. I really wanted to just simply highlight the diversity of the articles and the outcomes. Not only the methods used were quite diverse, the injury time between injury and assessment was diverse. The type of tools that we used varied vastly. And so you truly are never able to compare apples to apples. Essentially, every article is a different fruit. So those of us who try to work in this world and or try to look at the literature to try to help objectify our approach, find ourselves really at odds with trying to come up with concise approaches. And I'm sure that Dr. Yuen and others who work in this world with these special individuals can validate those struggles. This is a consensus group statement from England. In the adult literature that was relatively recently published, it too did the same thing. It basically highlighted all the challenges and limitations, albeit in the adult world, I suspect it's different challenges. Often adults have other comorbid challenges that influence, whether it be diabetes, congestive heart failure, medications that influences their symptomatology and the responsiveness to these tests. All of us, whether you're in the pediatric world and in the adult world, find it often very challenging to look through the literature and really put all the apples together and come up with a great consensus statement. This is a great article from Klaus and colleagues. What they did is they really focused on the limitations of the actual tests that we use. Whether it be growth hormone deficiency testing, gonadal assessment, or thyroid, it basically focused on one segment of what makes this such a challenging category or a group of individuals to care for. Those testing limitations include BMI factors, the agents used, the time in between the injury and the assessment, the timing of day. Do you consider the other drugs that are used? Often these individuals are on antipsychotics, depressive medications, or seizure medications. All these would potentially influence your thyroid results, your response to growth hormone stimulation, provocative challenges. And so as you can see, this becomes a very, very muddy or ambiguous group of individuals that makes it quite an honestly challenging group to try to diagnose. But at the end of the day, I really plead with all of you that we do have somebody who's standing in front of you asking for help. And they're saying there's something wrong. There's something that's not right. And one of my passions is helping people to try to discern, is there an organic endocrine cause for your post-traumatic brain injury complaints? If the answer is potentially yes, I find it appropriate to at least do a trial for some period of time to see if this helps alleviate those complaints and concerns. The review of literature challenges, some of which I've already discussed. Here's a great list of them. Glasgow Coma Scale This is a tool that we use, or the ER uses to assess the degree of injury. The question there is there's a lot of intra and extra personal variability. It's not very reproducible. Secondly, we don't know how to influence or how to interpret in pediatrics, or perhaps even the elderly who may have some neurocognitive associated preconditions. The timing between the injury and the evaluation fluctuates greatly, although the mean is typically about a year if you look through the literature. There are even fewer articles that have gone on to 5 years, which we'll talk about briefly. The biggest thing I want to highlight is really the pre-test probability, because all these tests, as Klaus and colleagues mentioned, have limitations. They're not perfect. But really, I think you can enhance the sensitivity and specificity by really choosing wisely which individuals you test. Other considerations, at least in the pediatric world, do you prime pubertally? Or even in a hypogonadotropic, hypogonadic adult, do you prime before you do stimulation challenging? BMI is known to inversely influence response, so do you factor that into the response? The different agents that are used, some of this is based on availability of products and really the ease of administration. We all know and accept the insulin tolerance test is the gold standard, but a lot of people have concerns about using that test in these groups of patients. Likewise, it's a very time-consuming, laborious study to perform, so most people probably use other surrogates. Assay variability, timing of day when you apply it, all of these things quickly add up to a lot of factors that contribute to the diversity in the data that's quoted in the literature saying what is the incidence of post-traumatic brain injury associated endocrinopathies. They vary anywhere from 10, 15% all the way up to 60%. And so it's really hard to say exactly what is the number, because there's just simply too many variables to consider. But again, at the end of the day, I really plead with you that we're really there to take care of the patient that's standing in front of us, who is simply complaining and asking for help, to say, is there anything that you can do to help me feel better and resume my previous injury quality of life? This is a great article that just recently came out. Again, due to the time restraints, I had limited articles to choose, and I thought this was a great one. This looked at a 5-year prospective study in pediatrics, looking at the incidence of growth hormone deficiency and pubertal alterations. And as you can see, it's highlighted here. Of the 61 individuals that are followed, at year 1, 17 of 61 were diagnosed with growth hormone deficiency, which is a fairly significant number. And they used a fairly stringent, or I think nationally and internationally accepted diagnosis, meaning a threshold of less than 7. At the 5-year mark, what they noted is they reevaluated those 17 individuals, and essentially 6. The reason why there's a quotation is the 6th individual actually had multiple endocrinopathies. So those 6 of the 17 continue to have confirmed growth hormone deficiency. Additionally, there was 4 individuals that demonstrated precocious puberty, albeit of the 61, they didn't say in the article how many were prepubertal throughout the study, because as you can imagine, a certain subset were prepubertal, and over the course of 5 years, some of that subset appropriately moved into puberty. So it's really hard to say that. I think 4 of 61 individuals is an underrepresentation of how often precocious or even delayed puberty can happen in these individuals who suffer a traumatic brain injury. Here's a couple of references I used in this very brief but I hope hopeful educational presentation. To your left is the CDC report that was just given in 2018 that really did a great job highlighting and giving evaluation and management of mild traumatic brain injuries. I often use the analogy of a mild traumatic brain injury or even a moderate to severe, is it's much like a contusion or a sprain of the ankle. As we all suffered an injury, an ankle injury, it's not wise to fairly soon after the injury to go out and run and exercise on that ankle, because all you simply do is exacerbate the damage and perpetuate the recovery. This is really no different from a neurocognitive perspective from a CNS aspect. So I often talk to them, and this is highlighted in the CDC, that these individuals really need to rest the brain because it's critical. And the top right is a British article that does the same thing. It essentially references the adult literature and talking about when and how to diagnose traumatic brain injury induced endocrinopathies. That's fairly in line with much of the consensus statements or literature out there, that typically 1 year, at least 3 to 6 months following a severe injury, and annually thereafter, these individuals should be screened for potential evolving centrally mediated endocrinopathies. In the middle is a great summary article from Dr. Alan Rogel, who's a pediatric endocrinologist at UVA. He did an excellent job summarizing, attempting to objectify the limitations of the literature. The problem is, as I had already highlighted, there is just so many variables that are difficult to account for across articles. And so to come up with a consensus statement is virtually almost impossible. But with that being said, the CDC highlights that although the TBI meets the criteria for a children with special healthcare needs program and aligns with the criteria of chronic health conditions, research studies have not been able to identify the best tools to truly assess and manage the individuals. And I think that I've probably highlighted that fairly significantly. Likewise, Dr. Rogel also follows his summary article by highlighting that it's incumbent upon us as pediatric endocrinologists to really educate parents, colleagues, neurologists, and even rehabilitation specialists about the possible association with trauma and subsequent endocrinopathies. And really, to that point, that's the whole goal of this webinar, is really patient awareness. To that end, I'm really appreciative that the Human Growth Foundation has taken on this task. So with no further ado, I plan on handing off the baton to Dr. Yuen. As Dr. Steelman had mentioned, we're going to do questions and answers at the end of this, and I look forward to a stimulated conversation. Thank you very much.
Thank you for setting the scene and explaining to the audience that this is a condition that evolves. It's not it's an event followed by an evolving condition. And so what I'd like to do is to perhaps put some perspectives into the recent guidelines on growth hormone deficiency that has been published, putting into some perspective of how we can utilize those guidelines, and then hopefully coming up with telling you what's on the horizons. Although this is proving to be quite a challenging task, I hope that after this talk that you will get some perspective of how managing these patients and having some sort of a framework would help you when you're dealing with a patient sitting in front of you asking help in helping them to address their problems. So these are my disclosures. And as you can see here, traumatic brain injury and its effects on endocrine causes has been known for many years. And in fact, looking at the literature, it has been published and certainly has been reported almost 90 years ago. And in fact, in the Endocrine News magazine here back in 2014, in the main page here, it's been reported that more than 2 million Americans actually do suffer from TBI injuries each year, and urging that us clinicians, be it endocrinologists or even non-endocrinologists who encounter these patients, to take a closer look and do not dismiss these patients especially if they have suffered a severe head injury when they're sitting in front of you asking for help, because occasionally you will find that there will be endocrine disorders that are potentially treatable. Oops. So what types of patients that actually commonly present with traumatic brain injury? And this is a list here that I'm sure many of you that you're seeing, that this list is perhaps not actually surprising at all. And as Dr. Reifschneider had pointed out earlier in his slides, that you see that patients can be presenting in extreme ages. When they are young, they can present following sports injuries, motor vehicle accidents, and then also martial arts and boxing, which is actually becoming more and more recognized. Domestic violence is another important area that perhaps is severely underreported for obvious reasons. And then you also get the folks that are serving, they're being deployed in war, that are coming back and they have encountered blast injuries. And those folks need to be assessed as well, especially if they are presenting with symptoms. And then you also have the young child who falls, or even the elderly with frequent falls, young people who are involved in fights and brawls and all those types of things, and also activities that can also perhaps cause injuries which may actually not be relevant, at least during the time of the injury, by many people, and unless they are actually made aware that they need to be checked out. So the question then is, who should be screened for post-TBI hypopituitarism? And really, I want to emphasize the point that TBI patients, in terms of screening, should be individualized. And why is that? It's because there is absolutely no way that we can screen every patient that complains of having had a previous head injury, because I can tell you that almost all of us would have hit our heads at some point in our lives. So I want to draw your attention to a nice review paper that was published by the Irish group at the end of 2019, basically summarizing, or at least giving a pragmatic approach as to how patients with TBI should be screened. So they are recommending that all patients with complicated, mild, or repeated traumatic brain injury should be screened. Patients with moderate and severe TBI, and patients who are susceptible. And what do they mean by susceptible patients? Patients who have developed basal skull fractures, elderly patients where they have frequent falls that they may or may not necessarily report to you, patients who have had motor vehicle accidents, or patients who have had persistent seizures after having had the injuries. In recent years as well, there's also been some evidence that patients who have had injuries, who on imaging studies have found to have abnormalities there, those patients indeed would be good candidates to be screened. And as Dr. Reifschneider pointed to you earlier from his nice, elegant video, the reason being is that when you develop an injury from a trauma, you develop potentially hemorrhages, and those hemorrhages may or may not sometimes be picked up on imaging. But the fact of the matter is, when you actually can pick up something on imaging, be it swelling, diffuse axonal injuries, or even any areas where you can see hematomas or petechial brain hemorrhages, those patients by then would have had many neurons that have potentially been affected, and most likely may have underlying endocrinopathies as a result of the injuries. And this is an algorithm that was put out by this group. And what they recommend is that if you have a patient who has had mild, complicated, moderate, or severe TBI, it's important that during the acute phase, meaning the first 7 days when they're presenting themselves, it's very important to make sure that adrenal insufficiency is not missed. And so they recommend measuring cortisol levels in the morning, and this is and I've converted that into SI units. This is in metrics, and you can see here patients who have morning cortisols that are 11 micrograms per deciliter or less, or patients with morning cortisols between 11 to 18 with symptoms of adrenal insufficiency. Those patients need to be treated with glucocorticoid replacement. Again, it's important to highlight the fact that adrenal insufficiency should not be missed because they are potentially life-threatening, and therefore it is important that clinicians pay attention to that possibility, especially in the acute phase, because studies have also shown that if they do develop adrenal insufficiency, there is a good chance that they also have other hormonal deficiencies. And that's not hard to understand based on the histology slide that Dr. Reifschneider showed you, because the ACTH producing cells are mainly in the inner part of the gland, and by the time that they are affected, you can see that most other parts of the pituitary gland has also been affected as well. They also recommend a chronic phase monitoring, meaning between months 3 to 6 post-injury, and it's important to assess the full hormones, the full set of hormones that these patients have, and these hormones should be tested in the morning, 8 a.m. fasting, and if you have any doubt whether they have or truly have adrenal insufficiency, performing the ACTH stimulation test is reasonable. Then they also recommend after a year of the injury that these patients should be reassessed again, and around that time perhaps also testing for growth hormone deficiency as well, in addition to all the other hormones that are being tested. Then the question becomes, well, if you have screened these patients, when do you continue and when not to screen? This information here, it comes from the Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury, and basically they recommend by an expert panel to continue screening if patients continue to have persistent symptoms up to 3 years post-injury. And the reason being is that sometimes these patients can still present beyond the first year of injury. These patients may be delayed in terms of their presentation, and therefore continuing to monitor these patients is clearly very important. But again, a degree of clinical discretion needs to be exercised in order for you to determine which types of patients need to be screened over that period of time. Screening is essentially not recommended, especially in patients with persistent vegetative state or patients with low life expectancy. And that's pretty obvious, the reasons why screening is perhaps not recommended, because clearly altering or changing the progression of the disease is probably not going to be affected when you are treating these patients should they develop hormonal deficiencies. So the American Association of Clinical Endocrinologists guidelines were published end of last year, which I'm going to highlight here, and it's already been published, but it's specifically looking at the providing guidelines for patients with growth hormone deficiency. And the algorithm provided by these guidelines essentially state that if you are suspicious of a patient with growth hormone deficiency, and that means patients who present with a history suggestive of growth hormone deficiency, and as you can see here highlighted in the red font, that traumatic brain injury being one of them, and if they have a low screening IGF-1 of less than 0 standard deviation, further testing is required in the form of growth hormone stimulation tests. And there are three different types of tests shown below here that one can utilize. But as Dr. Reifschneider had pointed out earlier, the insulin tolerance test is not an easy test to perform. It's inherent with many difficulties, and certainly some patients are contraindicated from undergoing that test as well. And also patients who have had a traumatic brain injury, it is a little tricky to consider performing an insulin tolerance test that might lower their blood sugars and may predispose them to seizures. So not a very safe test to perform in these types of patients. The glucagon test is perhaps a little easier than ITT, but it's still somewhat difficult because it's generally a 3 to 4 hour test, and about 30% of patients can develop nausea and vomiting during that test. So it's not very pleasant for the patient. The most recently FDA approved test is the messi test, which I will talk a little bit in my next slide here. Why is it advantageous to perform the messi over the other two tests? Is because it's an oral administration. It only requires 4 blood draws, 30, 45, 60, and 90 minutes. And the test is essentially very quick, only lasts about 90 minutes, unlike the other two tests, which could be in the region of 2 to 4 hours. It's very well tolerated with minimal side effects and relatively few contraindications. So pretty much most patients can actually undergo this test, and there's no evidence that it does cause any low blood sugars, which is good, especially with patients with TBI, because again, you may not know whether you're actually inducing a seizure in these patients or not. However, if you look at the studies that are conducted on the messi test on TBI patients, and these are 2 pivotal studies that were published in JCEM, you will find that only between 11 to 20% of patients in this cohort had TBI. So basically what we are saying is that only a minority of patients studied for this test were TBI patients. So there's still a huge unmet need of a pure TBI cohort where this test should be conducted in to determine its reliability and accuracy of this test in determining whether these patients have growth hormone deficiency or not. So how is it performed? You basically weigh the patient depending on the weight. It comes in pouches. You have 1 pouch if the weight is below 120 kilos, and 2 pouches is used if they're more than 120. You dissolve it in water, and this is the picture of the messi, and you can see here, this is 1 pouch here. You stir the water gently, you calculate the volume. So essentially very easy, because in a 70 kilogram patient, you will need 70 mLs of water to be reconstituted. And you basically measure that volume and you transfer into a drinking glass and you watch the patient drink no more than 30 seconds. And then you draw blood at 30, 45, 60, and 90 minutes. And that's it. Once they are diagnosed with growth hormone deficiency, then it's important to consider growth hormone replacement in these patients. And here in the published guidelines last year, there is some guidelines as to how and what doses of growth hormone should be used for different types of patients, which is essentially based on the patient's age. The younger the patient, the higher doses you can actually start the patient with. The older the patient, the lower the doses, and that's primarily to prevent side effects from occurring in these patients. In addition, other types of conditions such as obesity, diabetes, or previous history of gestational diabetes, these patients may have a higher risk of developing diabetes. And as you know, growth hormone in high doses can actually aggravate blood glucoses. And therefore, lower doses are typically recommended in these susceptible patients. And the point of treating these patients is to target their IGF-1 levels to within the normal range in adults. Slightly different in children, but certainly in adults, you target the IGF-1 to fall within the normal range. So the question is, what's happening or what's new in the growth hormone realm? And we know that growth hormone injections are now currently being used, but they are given on a daily basis, which again causes problems with adherence. Why? Both in children and adults, they complain of the fact that sometimes these injections could be painful. Caregivers also find it difficult to give to children as well, because children don't like the injections. And as a result, it's not surprising to note that non-adherence occurs over time. And as a result, the thinking is that by decreasing the injection frequency using a long-acting growth hormone preparation may actually improve the adherence and thereby potentially improve clinical outcomes in the future. So this table here essentially summarizes some of the many long-acting growth hormone preparations that have currently being studied at various stages. This slide is not meant for you to read because it's pretty, there's a lot of words in it, but our main aim is to highlight to you that there are different types of long-acting growth hormone being developed. And currently, the two long-acting growth hormone preparations that have shown really good results with non-inferiority to daily growth hormone would be the somapacitan compound and also the Ascendis compound. And also, there's also a new clinical syndrome that is currently being proposed in a subset of patients with TBI, that is a subset of TBI patients who develop symptoms, very severe symptoms of fatigue and cognitive function. And these types of patients may have abnormal growth hormone secretion, but they may not necessarily be strictly growth hormone deficient. And in several studies recently that have been published have shown that growth hormone therapy actually substantially improves their fatigue and cognitive dysfunction. And what's interesting is that once growth hormone is discontinued, these symptoms actually return, indicating that growth hormone treatment in these patients does not completely reverse the underlying mechanism, but essentially it treats the problem but doesn't take it away completely. And neurocognitive symptoms in what we call BioFAC, which is brain injury associated with fatigue and altered cognition. You can see here the symptoms are pretty profound, and these patients are very, very unwell, and they feel awful. They are not able to go back to work. A lot of them complain of foggy brain, memory issues, slow processing speed, a lot of things that can actually impact their quality of life and also their executive function, and may impact also their ability to continue gainful employment, which is a huge deal for these patients. So what do we do when we have these patients? And here's the recommendation. Clinical discretion is obviously very important for patients who have had a history of traumatic brain injury. And for every axis, these are the recommendations. You screen them, you perform morning blood levels to assess for cortisol, you measure their TSH, free T4 for thyroid levels, you perform water deprivation tests if feasible in certain types of patients, or you monitor their electrolytes or paired urine osmolalities to assess for potential diabetes insipidus. For growth hormone deficiency, you measure the IGF-1 as a screening test, and then you proceed with a growth hormone stimulation test if they have low levels of IGF-1. And again, treatment is again with growth hormone replacement. Gonadal deficiency, you measure their testosterone, and potentially you ask the patient if the patient is a female patient who has not had menstrual cycles for a period of time. Other labs are recommended because it also, TBI patients are also susceptible to metabolic syndrome, so fasting glucose, A1C, lipids, and they are also susceptible to vitamin D deficiencies as well. So in conclusion, we currently do not have a consensus guidelines for patients who have had TBI in terms of assessing them for hypopituitarism. Therefore, screening programs are crucial, especially for those patients who are susceptible to develop TBI hypopituitarism. Hormone replacement therapy, especially cortisol deficiency, is imperative because these patients could potentially die if cortisol deficiency is missed in the acute phase. In the chronic phase, it's important to also assess the other hormones as well, just to make sure that they're intact, because again, it can affect their quality of life and reduce and could potentially affect their morbidity and mortality as well. Again, multidisciplinary team approach is essential. Continuing education is important to increase physician and patient awareness. And what's new? Massive testing is new for testing for adult growth hormone deficiency. We have several long-acting growth hormone preparations in the making. It's still not available yet, but it will be in the coming months and years. And there's also this new BioFact clinical syndrome, which is now being reported, where a subset of TBI patients may actually substantially benefit from growth hormone replacement. And therefore, it's important to be mindful that these patients are out there and they need to be tested appropriately. So I'm going to end my talk now, and I think we're open for questions.
Thank you all very much. So the audience, the questions are open. So again, the mechanisms for submitting questions are through the Q&A, or you can also submit it via chat. While I wait for a few other questions to queue up, I was curious if you all would share from your experience, what would you say would be sort of the typical profile that you might see of a patient who presents with TBI and history and endocrinopathy? Basically, from my standpoint, what would be, you know, the typical mechanism of injury for those individuals, and what is the chronology of how long it takes them from their injury to presenting to you all?
I guess this is Dr. Reifschneider. I'll take that on, given the fact that you're a pediatric endocrinologist, and as am I. I think it's an excellent question. The problem being is there's a wide variety of, by the time they present to you with complaints and when the actual injury occurred. So, and it's driven by, I think, one, awareness that the two are related, which is the point of, one of the points that I'm trying to highlight in this webinar. Number two, the mechanism, the severity of the actual injury, and not only the severity, but the type of injury, right? A stabbing or puncture injury is far different than an MVA injury or a fall injury, right? And so the injury itself also condones or conveys a little bit of an association to the risk factors. Although if you look at the literature, one article says there's no relationship between the severity of injury and endocrinopathies, and then there's another article that says there is. But common sense is common sense. I think what it really does is highlight the limitations of the articles and the tests we use. But if a severe injury or a moderate injury occurred at some point in time, then that's somebody who really needs to be monitored. In the pediatric world, we had the benefit of growth as an objective measurement. In the adult world, I'll leave that to Dr. Yuen, because I feel like that would be far more complicated.
It is far more complicated in the adult world, and I'm sure many of our audience who are seeing patients out there would agree with me. They see a lot of patients who come through the door and telling them they're fatigued, and they've had a bit of a head, they bumped their head many years ago. Does that mean that they are qualified to have a TBI assessment? Is difficult, and that's why clinical discretion is very important. Because you're not going to be able to assess and screen every patient that walks through the door who's feeling a little tired or is gaining a bit of weight and they are not able to lose the weight. And so that's going to be difficult. The other thing also is that there are injuries that can occur, not so much like a MVA where you have a big injury and the patient is severely disabled. You can have, in contrast, you can have injuries that are repetitive, like the sports injuries, like the boxing, like the NFL, and patients actually are pretty well, especially after they've had these injuries. They don't really complain much until you tease them out, tease the symptoms that they're presenting. So I think a clinical acumen is hugely important when you're managing or when you're screening these types of patients.
Okay, thank you. I'm going to roll two questions into one now. So there were questions regarding puberty, which again, you know, for an adult, it would be more hypogonadism. But for Kent, tell me or tell the audience a little bit about pubertal disorders you see, both central precocious puberty as well as delayed puberty. Do you have any thoughts or perspectives from that standpoint?
It's not really too dissimilar to the other individuals who come to us for either precocious or delayed puberty. The issue is discerning is the history, right? And these individuals, which is why I always ask, Have you ever had a head injury? I've even had one individual who had cancer and failed to tell me that they had cancer. So I ask all these questions. Have you ever had cancer? Have you ever had chemotherapy? Have you ever had meningitis? Have you ever had traumatic brain injury where you had to come to the hospital? Because they simply don't know that that event years ago has any relationship to why they're here today. So it's really no different than the typical patient. It's just that in the history, you've associated a probable or potential possible cause that's now manifesting with what you've got in front of you, whether it's early breast budding or testicular enlargement, as indicated in precocious puberty, or a delay in breast budding or a delay in testicular enlargement in a boy.
Okay, thank you. Two questions for Dr. Yuen. First, has there been any association with thyroid dysfunction and BioFac? And then second, this may also be for Kent as well, massimorelin, has that been used also for stem testing in children or people right on the cusp of pediatric and adult age group?
Okay, so question one, is there thyroid dysfunction in BioFact? So typically BioFact is a condition where you essentially assess all their hormones at the very outset, and you replace all their all these hormones if they're found to be deficient, thyroid included, testosterone included, and these patients are still profoundly fatigued and profoundly unwell, and they're not able to function. No matter how much you push the dose, and I'm sure many of you who treat these patients have encountered that. You push the dose where the levels are in the upper half of the normal range, and patients still come back to you and telling you, doctor, I'm still not quite there yet. And that's when you would consider and typically confirm that they have growth hormone deficiency, and then you treat them with growth hormone at least for 12, if not 18 months, because growth hormone treatment doesn't improve immediately. So you have to stay with the cause, and that's important to tell the patients. And then they do find that there's an improvement upon replacement with growth hormone. So that's the crux of these types of patients. And then when you stop growth hormone for whatever reason, be it insurance issues, there's a gap, the symptoms come back despite being on hormone or full hormone replacements for other types of deficiencies. Number two, has massimorelin been used in pediatrics? Technically speaking, the studies that I presented to you earlier were done in patients between ages of 18 to 69. So technically, the FDA has not approved the use of massimorelin in patients below 18. Now, I do know that studies are ongoing in massimorelin. It hasn't started yet, or at least the recruitment, I don't believe has started yet, but certainly study design and of massimorelin in the pediatric cohort is now ongoing, or at least there's been talk that it's going to happen. So I guess watch this space, because it's going to happen. But until now, technically, it's still not approved for use in kids yet.
Okay, thank you. The next question is if you have somebody who has basically other multiple pituitary hormone deficiencies and a low IGF-1, is growth hormone stimulation testing actually necessary?
Depends on how many hormonal deficiencies you have. So if you have 3
Okay.
or more with a low IGF-1 as defined by IGF-1 below the reference range for that appropriate age and gender, then 95% of the time these patients will have growth hormone deficiency, in which case growth hormone stim testing is exempted. Otherwise, it's still important to perform the growth hormone stimulation test. Now, personally, in my practice, I would still do a growth hormone stimulation test in these patients. And the reason I do that, as well as the way I explain it to the patient, is, well, because insurance companies, really just to make sure that insurance companies would approve it. Because what I don't want is when the patient was never tested because they have 3 or more and low IGF-1, and then 5 years down the line, the insurance company says, well, we're not covering this. And then I can still show them, but at baseline, before any growth hormone, with 3 or more deficiencies and low IGF-1 and a growth hormone stimulation test, please continue coverage of these patients. So that's kind of what I've done, but in essence, you don't really have to.
Okay. The next question is about quality of life assessment instruments. There are some obviously for adults. Tell me from both of your perspectives, do you all use quality of life assessments either informally or formally when looking at hormone replacement, particularly growth hormone replacement in your patients?
So we have the luxury or the fortune of having a fairly good rehabilitation subspecialty practice here, and within that group is some neuropsychologists, and so they do perform quality of life assessments. In fact, they're the ones who tend to send the patients to us. As you would imagine, shortly after an injury, the rehabilitation group and the neurologists are the ones who predominantly see these individuals. And so it's really, we're the last to ever see these patients, which I don't think is ideal. And this is where awareness, such as these webinars, are critical to really get the word out to PMNR and neurologists to say, hey, although we know to send them to those groups, they also need to keep in mind at some point in time, they need to be seen by an endocrinologist. So the vast majority of these individuals already have that assessment done before I see them.
Okay.
And then for the adult cohort, quality of life assessment actually is something that is important. And in the UK, they need, in the United Kingdom, they need that as part of their coverage for growth hormone. Here in the US, I use that especially for my TBI patients, because I like to at least give them an objective assessment of how they feel before and after growth hormone treatment. So, and a lot of these patients, like they like it, they see it, okay, this is what I felt last time and this is how I'm feeling now. So it's it's perhaps it objectifies a little bit of how they feel and helps them understand their disease better. But otherwise, I would think the assessment of quality of life is still something that is hard to assess in TBI patients, because they have many other things that are going wrong in them, simply because it's the injury itself causing their symptoms and not necessarily the hormonal deficiencies.
Okay, thank you. Well, we have a lot of good questions. I'm going to catch one more question here as it's kind of cutting edge, and then we'll need to wrap up. So the question is about imaging studies. So of course, there's traditional imaging studies of MRI and CT, but are there any more cutting edge types of technology that you all are using or that you find useful in traumatic brain injury?
I'll defer to Dr. Yuen, because I unfortunately don't have access to cutting edge technology at a time.
Yeah. So yes, so this is still an area that is that requires a lot of studies. And usually what I do is I work very closely with my neuroradiologist colleagues. And certainly if there are MRI evidence of bleeding or previous bleeding, or sometimes even CT scans that might help, that can sometimes be helpful. There's also an area that I think is pretty important, which is the DTI, diffuse tensor imaging studies, which I think is still very much in research. I don't think it's still prime time yet. So I think in terms of those studies, it's still very much in studies, and we still don't know, and it still needs validation to see if it does help us to predict whether or not these patients would develop TBI endocrinopathies in the future. No, but it would be very cool if we have such a tool to help us to predict, and because it will also definitely help us to counsel our patients as well.
Thank you. I want to thank you all very much for taking the time and presenting these very interesting lectures on this topic.